to you all in our lovely lecture theatre, and good evening to our Zoomers, and welcome to one of the highlights of York Medical Society's calendar, a Founders Prize evening. Tonight we come together to celebrate the spirit of inquiry and pursuit of medical progress. The Founders Prize is a long-standing tradition of the Society, established to recognise and encourage the next generation of medical researchers. It reflects the vision of our founding members, who believed that the advancement of medical knowledge should be at the heart of our profession. This evening, we have the privilege of hearing from 5 talented doctors, each presenting their work which has the potential to shape clinical practice and improve patient care. Their work spans a range of medical disciplines, and each project represents dedication, intellectual curiosity, and a commitment to evidence-based medicine. I'd like to introduce and welcome our judges for this evening, who are Dr. Mark Roman, Professor Matt Morgan, Professor Jim Drive, and Dr. Sarah Anderson, and they will be judging your presentations this evening on their delivery, the skills exhibited and your slide design, the originality and the quality of the topic that you've chosen, the clarity of outcomes and benefit to patients, how you keep to time, and the responses that you give to the questions. So each speaker will have 12 minutes for their presentation. I will hold up a green folder right there when it's 2 minutes to go and you need to be going to the finishing line. Don't panic. I will then invite a few questions from the floor. Can I ask our presenters, if I forget, to repeat or paraphrase questions from the floor so that the Zoomers can hear them and can be fully involved, as well as it giving you a bit more time to think of what you're going to respond. So after all the presentations, our judges will deliberate and we will announce the winners of this year's Founders Prize. However, as always, the true value of this evening lies not just in the award, there's only one winner, but in the exchange of ideas, the discussions that follow, and the inspiration we all will take from these outstanding contributions and the enjoyment of actually being together. So the prize giving being over, you're then free to have some pizza and refreshments together outside. So may I introduce our speakers in the order of delivery? Yeah. So first up, we've got Sonya Bushell. And then we have Dr. Kafanu Apuhami. And then we have Dr. Hannah Foster-Rain. And then we have Dr. Isabel Austin. And then finally, we have Dr. Christina Christian. So they're all here. That's a great start. And all your slides will be there. So without further ado, can I invite Dr. Sonya Bushell to come up and get the ball rolling. And if I can connect you to the loop thing. So if you want to put it on, and then pop this in the pocket somewhere, try and switch it on. And we're good to go.
Set time for me, if that's okay. Dr. Sonya Bushell, and I'm a doctor working in palliative care at the moment. I'm going to be talking to you today about a project that I did during my academic foundation programme. There's never really been an opportunity. Perspectives of those with long-term conditions on advanced care planning, a qualitative interview study in primary care. Sorry, how do I change the slides?
Just click the arrows or, yeah, that's it, you've got it.
Okay. So advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values and preferences. However, despite that quite broad phrase, what we find is that actually advanced care planning is often only discussed in patients approaching the end of their lives, normally those with frailty, deteriorating health, or those in the very last days of their life sometimes. As you can see, the Respect form is an example of an advanced care plan that happens. It is now happening more around the country, but as I said, it is often in that very late stages of illness. So my research was interviewing people with long-term chronic conditions, managed in the community in primary care, asking them how they thought about the future and their attitude to discussing advanced care planning. So there was mixed method recruitment via GP practices in North Yorkshire. Semi-structured interviews were recorded and transcribed by myself, coded using NV software, and there was thematic analysis that took a critical realist approach. And once I summarised my findings, I then emailed them back to participants to get their feedback as part of a respondent checking process. So it was 21 patients interviewed, plus 2 friends and family members, a range of different settings, quite a broad age range, 61 to 91 years old. And what's interesting is that most of the participants were not frail, which is quite new because most of the advanced care planning research that you look at has been done in cohorts that are more frail. As you can see, there was a mixture of cardiovascular disease, long-term respiratory disease, and diabetes. And the majority of people were living with multiple long-term health conditions, which reflects the population as we know. So very few participants that I spoke to actually understood what the term advanced care planning meant. But despite that, many of them had actually engaged in various bits of planning for the future, whether that was things like making a lasting power of attorney or starting quite general discussions with their family about what they would want if they became unwell. But very few actually knew that there was a formalised process that they could engage in, and very few had actually discussed this topic with healthcare professionals, which I think is quite interesting because it suggests that people are quite open to it, but that they're not necessarily being given the opportunity. So as I talked to people about advanced care planning, I learned that there were kind of 3 different ways that people spoke about advanced care planning, 3 different kind of forms of advanced care planning. And I'm going to go through each one now. So the first one was kind of advanced care planning as proactive planning. This was kind of people who were generally quite fit and well, but who thought that they wanted to plan for the future as a sensible thing to do, really. Things like making a will, making a lasting power of attorney, maybe having some general conversations with their family and friends. And this was often understood as a kind of administrative task and not really related to any kind of emotional conversations, because people felt that they were kind of preparing for themselves for quite a distant future and they weren't imminently worried about their health. Then there was the advanced care planning that was about preparing for change. And this might be somebody who received a new health diagnosis or who was aware that their health could change in the future. And as somebody said there was this kind of desire for information because often people were receiving health diagnoses and not really receiving any information about what their future could look like. And somebody said, when you're giving someone a new drug or you're going in for an operation, they have to talk about the side effects or what may go wrong. I think it's nice to know what your options would be. And it suggests that perhaps there's a cohort of people living with long-term health conditions who aren't really receiving the information that they would like to receive about their future. There's the advanced care planning conversations around facing mortality. And those conversations are generally when people are experiencing quite severe ill health, who are at risk of dying. But even in the more general senses of advanced care planning, I guess there is always that recognition that advanced care planning may involve discussion of one's own death. And people spoke about the fact that there were different attitudes to this. Some people were very open to talking about death and very much wanted to talk about it. Other people thought that actually it could be quite a sensitive topic. And one person memorably said, unless the person thinks when they see this respect form, my God, they think I'm going to die, that could be the finishing touch of life, which suggests that different attitudes. So what I'm suggesting based on this research is that perhaps we need a new model of advanced care planning. Traditionally, we've very much researched advanced care planning in the kind of facing mortality, terminal illness context. Was actually there's a whole cohort of patients for whom advanced care planning might be relevant and who might actually be quite open to discussing this, but who we haven't really asked about their opinions on it. And perhaps also we could extend advanced care planning beyond the kind of advanced illness to the kind of chronic illness and even public health and societal education initiatives. Just briefly want to mention a bit about advanced care planning within proactive healthcare. There's a lot of talk at the moment about the NHS long-term plan, moving healthcare into the community, preventative healthcare. And perhaps there's an opportunity here for advanced care planning to be integrated into some of those discussions. It was very clear that participants were very open to having more proactive healthcare. And one of the participants had actually asked their GP for an NHS pamphlet on ageing because they were very keen to know about their future health and how they could stay healthy and what kind of things they wanted to do. But they had just been told by their GP that that's not what we do. And as we kind of talk more about preventative healthcare and moving healthcare into the community, perhaps there's a potential to integrate advanced care planning into this. And one participant said that when you turn 60, you get told to do a wee in the bottle or poo in this thing and it gets sent off. But perhaps we also need to start thinking. And perhaps alongside telling people all the amazing things that we can do to try and keep them healthy, perhaps there's also potential to open up conversations about what they would like if they become more unwell. And actually, I think that this is potentially would be less threatening and less worrying doing it in this way than in an emergency. And as one participant said, if it comes in a caring way, I think that would be fine. I would think most people would just appreciate the fact that the surgery is bothering about this. I did want to note that there were some concerns about kind of extending advanced care planning conversations. Some people very much wanted to discuss advanced care planning with a senior healthcare professional. Others wanted to wait until they were ill to make the decisions. And some people raised concerns about vulnerable people, such as those with mental illness, living with distress, or those with learning disabilities. So, just to discuss the kind of strengths and limitations of my study, I think this is new data in an under-researched area. It is very rare to kind of see advanced care planning research in populations that aren't kind of imminently expecting deteriorating health. There is the danger of self-selecting bias in that I guess the participants who took part in my research were already probably those who were more open to discussing their future and their health. It was a non-diverse study population with an absence of people under the age of 60. And it was a snapshot study, and it would have been interesting to kind of have maybe do this longitudinally and see whether participants change their mind about advanced care planning as time passes. In terms of implications for the future, one thing that really came out is that advanced care planning is a very poorly understood term. And I know that Scotland is actually changing to future care planning, which might be a better way of phrasing it. I think there is potential to integrate advanced care planning within more proactive care, and particularly with reference to kind of things like the long-term plan for the NHS, and potentially signposting to ACP within more public health and preventative healthcare consultations. In terms of future research, there's three kind of key things that could be considered. Exploring professionals' thoughts, in terms of the workload and the logistics of discussing advanced care planning. I think there is a need to research the risks and benefits of discussing advanced care planning within particular vulnerable cohorts. I know that King's College London is doing quite a lot of work in advanced care planning with people with learning disability, for example, because that's kind of something where you want to get it right and not cause distress. And then potentially doing pilot implementation studies where you actually implement a form of advanced care planning or a communication about advanced care planning and actually see how people respond to that, kind of the risks and benefits of that approach. Thank you very much, especially to the primary care GP practices that helped me on research. Happy to take any questions.
Well done. Questions from the floor?
Just ask, how did you select you may have mentioned this at the very beginning, but how did you select people?
Yeah, thank you. Just to repeat the question, that was about how I selected the people who took part in my research. So this was mixed methods recruitment via different GP practices. So first of all, in order to take part in the study, you had to be living with a chronic health condition, particularly cardiovascular, respiratory or diabetes. There were posters and leaflets up in the waiting rooms. GPs and other healthcare professionals could hand out information to patients, but due to the kind of NHS ethics process, I wasn't allowed to directly approach patients. All the patient participation group members were emailed. And there was also, later on in the study, I got permission to share it on social media pages. So, for example, if there was a GP practice in a local town, I could then share information about my research project on local Facebook groups associated with that.
Okay. Well,
Yes.
I used to be a geriatrician in York, and it was patients had had a conversation. It needs to be anything formal, but a conversation with their family. Because I dealt with a lot of people who were dying, and many of the time they weren't expecting to be dying, but you were trying to find out what they really wanted. And one of the difficulties was explaining that to the relatives that it's not about what they wanted for their mother, father, or whatever. It was what the actual patient wanted. And some families understood that, but for others it was a case of you're trying to make a decision, you know. And I think the whole concept of advanced care planning, it will be really, really useful in that sense, because it made a huge difference to the way you could then both manage the patient and manage the family's expectations.
Thank you. Just to kind of summarise that comment, that was about the fact that when patients come into hospital and we're asking their family members, you want to be asking their family members what that patient themselves would have wanted, rather than communicating that you're asking the family member to make decisions. And I think that's where things like the respect form could potentially be really helpful if they were used, because then you've got some kind of documentary evidence of what that person's wishes and values are, and you can then refer back to it. And I do think there is a pressure sometimes that family members wrongly misinterpret otherwise, that they are being asked to make decisions and sometimes carry that kind of decision-making burden when they wouldn't necessarily have had to.
Especially, where do you be storing these forms or this information in a GP primary care record, with your solicitor, with your will, somewhere in social media that we haven't got?
Thank you. A very salient point about where we actually store these forms. I think it's really tricky, because I think with the respect form, kind of the idea is that it stays with the patient, but I guess quite realistically, people aren't going to necessarily want to carry their respect form around with them everywhere, particularly if it's kind of maybe perceived a bit negatively. And even putting it on the fridge or something is maybe not what you want to look for when you're looking for the milk. But the idea is that it does stay with the patient. There is now a move towards kind of integrated electronic records. So the kind of EPAC system is meant to be the system where all the kind of advanced care planning that's been done in primary care is then available to the ambulance service, etc. Very interestingly, in theory, that's meant to be happening in Yorkshire, but when I speak to paramedics on the ground, they're not aware of this system. So I think it is a case of maybe the theory hasn't really caught up with the practice as such. But technology may be the solution in future.
Time for one more question. Yeah,
Was there any by any of the people that you interviewed, say, change their mind?
So that was just to summarise. That was a question about what anxiety around changing your mind in the future. There was a little bit. There was kind of an anxiety more about kind of how the NHS would store it, in terms of there was a bit of distrust about letters being missed, or people had issues where appointment letters don't arrive, and then like, well, how do I trust a system that has that? And then around changing their mind, people did talk about kind of wanting to be able to revisit their decisions. And these patients that I was interviewing were often the patients who were having annual health checks in their GP practice. So then it was kind of felt quite natural that potentially that could be reviewed on an annual basis within primary care, because that's what, at a stage when you're coming back to be checked. The danger would be, I guess, if you've changed your mind in between those 12 months. And I guess, yeah, maybe having a way of communicating to patients, if you change your mind, this is what you need to do, and this is who you contact, etc.
Great. I think we've got about a minute to make it fair, so carry on.
Thank you very much. There has been a slight shift in the number of people dying at home or in hospital.
Thank you very much. Just to summarise, that was a question about preferences around place of death. I didn't specifically ask about people's place of death as a preference. I was talking more generally about their kind of wishes for end-of-life care. But what was interesting was that I think most people were kind of quite focused on their symptoms being well managed, and they weren't necessarily expressing a place of preference for death as much. But people were very wary of not wanting to have lots of medical interventions. Some of them had experienced quite what in their mind was over-investigation in the hospital setting, and they wanted to avoid that. But they weren't necessarily against going into hospital. They just wanted to kind of avoid some of the more invasive medical interventions.
Right, thank you very much. If I can
Thank
take the device now.
Good evening. My name's Kevin Diopahami. I am an academic clinical fellow currently training in psychiatry. I spend some of my time doing various bits of research, and this is a project that I led titled People with Severe Mental Illness Are Not Adequately Screened for Non-Communicable Diseases. These were the findings of a multi-country cross-sectional study that took place in South Asia. So quickly, just a brief outline of what I'll be talking about. I'll give a bit of a background as to why we chose this specific topic and this population, go through the methods, some of the key findings, and discuss the significance of those findings. Talk about some of the things we did well, some of the things we didn't do so well, and hopefully end with some take-home messages that might actually be quite generalizable to the population here as well. So I thought it'd be good to start by thinking about on an individual level, a person with a severe mental illness, which is an umbrella term for a variety of diagnoses, namely schizophrenia, bipolar disorder, major depressive disorder. And thinking of that individual living in a South Asian country, and I identified maybe 3 key challenges that such an individual might encounter. So firstly, someone living with SMI, severe mental illness, they're likely to be less active. They're likely to make poorer lifestyle choices, drinking alcohol, smoking cigarettes, and also taking medication for their mental health problems that actually have quite severe side effects and can lead to their own problems. Living in a South Asian country, many of these countries are low and middle income and likely have poor access to healthcare resources. And many of the individuals there have a reduced awareness of the impact of their behaviors on their health as well. And that's probably magnified in a population where they're already encountering severe mental illness. And unfortunately, being South Asian means that you're genetically and environmentally more likely to develop an obesity-related non-communicable disease. The ones we focused on were diabetes, high blood pressure, and high cholesterol. So when you take all of these 3 things into consideration or into combination, it unfortunately leads to a significantly increased risk of developing metabolic syndrome and cardiovascular disease. So why is this study important? So we know that people with severe mental illness probably have a life expectancy of 10 to 20 years less than the general population, which is an astounding amount. And it's largely contributed by these non-communicable diseases that I've mentioned. We know that screening for non-communicable diseases is a cost-effective approach to managing them and identifying them early. And this can be adopted quite widely in a low resource healthcare setting, such as those that we might find in the low middle income countries that we're looking at. So managing non-communicable diseases in people with severe mental illness is already a priority in many high income countries. And that's a great example of that is in the NHS. We use something called the Leicester tool, which is a cardiometabolic risk tool, which identifies people who are most at risk of developing specific diseases and also outlines a quite clear management plan for them as well. So if we're doing that already in these high income countries, why are we not doing it in these settings where these people are probably even at greater risk? So what do we want to find out? So the primary outcome was looking at the proportion of individuals who were screened for a non-communicable disease and then offered health risk modification advice. And the secondary outcomes were actually looking at specific socio-demographic variables and identifying if they increased or decreased the likelihood of being screened for a non-communicable disease. So how did we carry this out? So this was a quite large multi-country cross-sectional survey that took place across India, Pakistan, and Bangladesh. It recruited 3,989 participants across these 3 countries, and this was a secondary data analysis based on the large data set that we gathered. So the main inclusion criteria were individuals who were adults over 18 years old with an SMI diagnosis and who were able to consent. So we tried to keep it as inclusive as possible. So they were randomly selected from 3 national mental health institutions across these 3 countries. And after consent was gained, they then spent about an hour with our trained research staff on the ground there, carrying out quite a detailed survey, which looked at various socio-demographic variables, details about their physical and mental health. We also took blood tests and carried out specific measurements like height and weight to calculate BMI to give a really comprehensive picture of their physical and mental health. And based on the data that we gathered, I selected the variables that I thought were important in this case, and we created a logistic regression model to try and identify the associations between these variables and the likelihood of being screened. So what were the variables we used? So the dependent variables were the three conditions we mentioned: hypertension, diabetes, and high cholesterol. And it was based on a self-reported outcome, really. The participants would tell us if they have previously been screened or not for these conditions. The independent variables were the ones we selected, which we thought would hopefully provide us with some useful answers, looking at things like age, sex, the type of SMI diagnosis, the level of education, employment status, and their income as well. So what did we find? So we found that high cholesterol was consistently the least screened in all three countries. And conversely, hypertension was the most screened across all three. And I guess that makes sense because measuring cholesterol involves taking a blood test, transporting it to a lab, usually involves lots of costs to the individual themselves, whereas high blood pressure can be measured from a blood pressure cuff. It's much more easily accessible for many people. And also, I guess that also explains why high cholesterol was the most prevalent non-communicable disease that was newly diagnosed through testing. So we actually found that around 45% of participants in India and Bangladesh were newly diagnosed with high cholesterol from our study. And over half, 54.2% of participants in Pakistan were newly diagnosed with high cholesterol just because we told them they had it after the study. So you can imagine that means that represents how many people might be living with these conditions, not knowing that they have them, continue to live in the same way, and how to manage these health problems. Dietary advice was the most common health risk modification advice that we offered. But even then, only 5% of participants actually went on to adhere any of the advice provided. So there was still, even though we were providing this advice, there's still a barrier to how it's being implemented and utilized. So the socio-demographic variables that we used in these logistic regression models, I've picked out a few key ones. So participants with obesity were 53% more likely to be screened for a non-communicable disease compared to those with normal weight. Participants with bipolar disorder were more likely to be screened for non-communicable diseases compared to those with schizophrenia. Female participants were actually 29% more likely to be screened for non-communicable diseases. And participants with higher or more than secondary level of education were 61% more likely to be screened compared to those with no formal education. Apologies for using that icon for anyone over the age of 55. So anyone over that age, 3 times more likely to be screened for communicable diseases. And participants in the highest income band were 20% more likely to be screened compared to those in the lowest income band. So what do those results actually mean? So I guess there's a considerable variability in the screening rates across all of these diseases in all 3 countries. And we found that people who were more educated were more likely to attend screening. That probably is to do with the fact that they have a high level of health literacy, understand more about their health, maybe take more educated health conscious decisions, and are more likely to participate in something like a screening program. We also need to factor in the financial costs of attending these screening programs. Unfortunately, not everyone has the luxury of having quite freely, readily available things on their doorstep. It often involves transportation costs, getting there. A lot of these people are quite vulnerable, need people to take them to these things, and all of those things need to be taken into consideration. And we think the reason that schizophrenia, people with schizophrenia were less likely than those with bipolar disorder to attend may have something to do with the undertreated negative symptoms of schizophrenia. So that basically encompasses the symptoms of being isolated, being depressed, And then also thinking about diabetes and high cholesterol screening for people with SMI. It was actually people with SMI were being screened about the same rate as those in the general population, which maybe highlights that it's not being prioritized by the healthcare systems in these countries. We also need to think about the stigma associated with these things as well. So just quickly, some of the limitations. There's a cross-sectional study. We couldn't really establish any causational relationships between the variables that we looked at. There were probably a lot of unmeasured variables because of how complex this topic is. Recall bias is a huge one. We really relied on the participants' recall of if they've been screened for these things or not. They may well have some of them when they said they weren't. And the selection bias, we only really surveyed the people who were coming and attending these appointments. So actually our figures could be really underrepresenting how big of a problem this is. The strengths though is probably the large sample size, and it is a hugely underrepresented population as well. So quickly, take home messages. There's a low uptake of screening in all 3 countries. Males with severe mental illness from the lowest income percentile and the lowest educational attainment were the least likely to be screened, which I think underscores the perpetual cycle of inequality that we're seeing. The people who are actually already the most disadvantaged are not receiving the support that they need to break that cycle to improve their health. But that probably takes me to time. Okay. That's the end.
The motivation for screening, does that come from the individual, from the system identifying them and offering screening? The person?
So that question was around the motivation for screening, whether that's from the individual. I suppose you're asking if they're coming themselves to ask for these things or if they're being offered from a program. So I think what we found from all 3 countries is there is no established screening program, which I think is highlighted by how poor the screening rates are. But what we would expect is that the physicians working there with these patients are offering some of these basic things anyway. A lot of these patients are on medications such as antipsychotics, where they should really be having these blood tests and some of these physical health measurements as a baseline. And we're finding that that's not happening.
Yeah, really nice. Enjoyed it. The other bit that was really striking though is that even when you screened and given advice, there was just almost non-existent adherence. So
yeah,
there's only benefit in screening than to be
yes,
the route to meaningful intervention.
If you can summarize it.
Yeah, so in summary, Matt was just asking about how we kind of ensure that screening leads to improved health outcomes. I suppose the answer to that is kind of in the idea of this health literacy and how people are able to utilize the advice that they're given. Because as you said, you know, we're giving the advice, but not everyone is taking it. So I think the only way we can establish that is by ensuring people understand the importance of that. And I suppose that's a much wider problem and probably starts from teaching them from an early age about the importance of these health decisions that they make. But yeah, that kind of goes beyond the screening program itself. But I guess we're looking at this from a spotlight of how the screening's working. Yeah.
Over to you, Paul.
Thank you. I'm over 55. Age black. So I'm a psychiatrist actually, so there's no context in which these tests are being done. So in England, we have we have a community mental health team and a physical well-being healthcare practitioner whose job is to screen them, or a GP, or both. I'm not sure in these South Asian countries what the system's like. Do we have fancy multiple disciplinary teams in the community, or how's it working? Is it in hospital?
So that question is around how the system is structured in the South Asian countries regarding how they might be screened for these non-communicable diseases. The answer is quite disorganized, so that there isn't kind of the structured tier system that we have of like a CMHT, then more specialist services. Often the inpatient and outpatient facilities are almost in one building. So what would happen is the inpatient consultants will see outpatients on kind of a few hours every day. And I suppose the best way to implement these kind of screening programs would be that there might be a dedicated nurse that might kind of be linked in with the physician that's seeing these patients and ensure that they are having the necessary screening for the conditions that are most likely to affect them. That's probably the easiest way to implement that.
That's not happening at the moment. Not systematically.
It's a bit more sporadic. It's not. It's a kind of ad hoc basis, really. Yeah.
Thank you.
Thank you very much.
Perfect. Well, thank you everybody for inviting me to speak today. I'm here to present my research study, spinal anaesthetic with intrathecal diamorphine in robotic assisted colorectal surgery, which is a retrospective cohort study. It's something that I've been working on throughout my foundation programme at York. So to provide a bit of background as to why we decided to undertake this study in the first instance, within the field of perioperative medicine, there's a really strong consensus towards opioid avoidance within colorectal surgery. And these recommendations come from the Enhanced Recovery After Surgery guidelines, which are widely considered the gold standard, but also from a recent consensus statement from the British Pain Society and Association of Anaesthetists. And these recommendations come from a growing evidence base that recognises the undesirable side effects of opioids on multiple organ systems. So you've got increasing rates of sedation and opioid-related respiratory depression, ileus, constipation, and also patients' ability to engage in rehabilitation programmes. Despite the really strong evidence advocating for its use, some studies have highlighted some potential side effects of spinals, including things like post-operative nausea and vomiting and increasing rates of ileus and respiratory complications. Nevertheless, spinal anaesthetic is a really effective method of multimodal analgesia that can help reduce systemic opioid requirements and provide effective analgesia from the intraoperative period right through the transition period onto the ward. So robotic assisted colorectal surgery is a bit of a gap in the literature. As I mentioned, we've got really strong recommendations for the use of spinals within laparoscopic and open techniques. And robotic assisted techniques have been around a while now. And the general consensus is that they have the advantage of reducing post-operative pain, predominantly by reduced trauma at the port sites. You've got enhanced precision and enhanced ergonomics. And based on this idea of reduced post-operative pain, we hypothesised that perhaps spinal anaesthetic wouldn't produce any benefits in this patient population, and actually the risks of a spinal may outweigh benefits in this patient cohort. So this moves on to our retrospective study. The primary outcome was opioid administration within the intraoperative period and also 24 hours post-operatively. And this was measured in intravenous morphine equivalent in order to allow standardisation and easy comparison between the two groups. The secondary outcomes include a variety of post-operative complications, including things like ileus, post-op nausea and vomiting, but also length of hospital stay and unplanned admission to the intensive care unit. So our study was done at York University Teaching Hospital, and it included patients receiving surgery between May 2022 and also April 2024. It included data from 7 colorectal surgical consultants employing the Da Vinci robotic platform. So a total of 221 patients received robotic-assisted colorectal surgery within the study period. We excluded 20 from analysis because they required conversion to open surgery, and therefore we suggested that their opioid requirements would be higher. Some unfortunately had missing documentation or received alternative forms of neuroaxial analgesia, including epidural. And this left 201 suitable for analysis. Within this, 121 received spinal anaesthetic and 81 received conventional analgesia alone. So moving on to data collection, for the primary outcome of opioid administration, this was collected retrospectively using paper anaesthetic charts and also electronic prescribing records. The demographic data was collected prospectively at the pre-op assessments, and also the secondary outcome data was collected by the perioperative care teams who routinely follow these patients up on the ward, and they can provide a real-time account and record any instances of the secondary outcomes according to predefined criteria. Moving on to the statistical analysis. So we use univariate statistics to describe the distribution of the data. We realised that it wasn't normally distributed, so it's presented as median with interquartile ranges. We also use a Mann-Whitney U test to describe the statistical significance of the continuous variables, and chi-squared and Fisher's exact test for categorical variables. So moving on to the results, so the groups were well matched in terms of patient characteristics and also non-opioid analgesia used. The median intrathecal diamorphine dose was 700 micrograms. Within the spinal anaesthetic group, they received a median dose of 0 milligrams of morphine. The conventional analgesia group received a median dose of 10 milligrams of morphine. So within the post-operative period, which was 24 hours, the spinal anaesthetic group received a median dose of 5 milligrams of morphine versus 20 milligrams in the conventional analgesia group. And again, this was a significant result. So moving on to the secondary complications, we observed that there was actually no difference in any of the predefined secondary outcomes identified, including there was a trend towards reduced rates of post-op nausea and vomiting, but this wasn't significant. And there was also no difference in length of stay or unplanned admission to the ICU. So in terms of strengths and limitations, so this provides a pragmatic analysis of patients undergoing robotic-assisted colorectal surgery. It was well balanced despite the retrospective study design, and also the outcome data was prospectively collected, which improves the accuracy of the results. In terms of limitations, obviously it's a retrospective study, so it does have significant limitations that I'm not alluded to. But first of all, there was no perioperative protocol, and this meant that the anaesthetic that was given was up to the discretion of the responsible anaesthetist, and therefore there was quite significant heterogeneity in the analgesia used throughout the perioperative period. And we were unable to convert the non-opioid analgesia into intravenous morphine equivalent, and also the intrathecal diamorphine dose. But unfortunately, this is a limitation of all studies that investigate intrathecal diamorphine and use opioid administration as a primary endpoint. And, you know, again, as it's a retrospective study, we were unable to exclude case selection bias. Ultimately, the anaesthetist choose the anaesthetic regime according to what is best for the patient. So there's a possibility that they choose patients who are going to reap the most benefits from spinal anaesthetic. So, in conclusion, we observed that spinal anaesthetic appeared effective in reducing opioid administration in patients receiving robotic-assisted colorectal surgery. But unfortunately, this didn't translate to any difference in secondary outcomes. So obviously, you know, these results are promising. Unlike previous literature, it didn't show any increase in complications associated with the spinal, but I'm under no illusions. The retrospective study design does mean that there's some limitations. The purpose of this study was to be hypothesis generating, and therefore we're using this study to provide the background in order to get a research grant in order to fund a prospective randomised controlled trial with a formalised perioperative protocol. And we're also using the research to improve patient experiences on a local level. So in the results section, the median intrathecal diamorphine dose was 700 micrograms. The general consensus recommends that doses above 500 mics increase the risk of complications, but don't necessarily constitute superior analgesia. And therefore, we're doing qualitative research in the form of surveys to understand why these doses of diamorphine are being given to patients, and also barriers to patients accessing a spinal. We're also trying to introduce a protocol where patients receiving the higher doses of intrathecal diamorphine are admitted for a period of enhanced observation, just to make sure that these patients are safe. Although it is worth noting that we didn't identify any instances of respiratory depression to any of our patients within the study period. So on reflection, I've been involved in all stages of this research project, from study design, data collection, working with the perioperative care teams, and have, been involved in creating multiple drafts and have submitted it for publication. It's been incredibly hard work, but rewarding. It's taught me problem solving. I've had to learn statistics, and ultimately, it's created something that's having a very real impact on patients receiving robotic colorectal surgery at York. Which is, one of the most vulnerable times in a patient's life. When I think about what I would do differently, so we chose perioperative opioid administration as the primary endpoint because it's a nice objective measure or surrogate of pain. But ultimately, through my literature review, I've realised that more functional endpoints, such as patient satisfaction, have a far more significant impact on more clinically relevant outcomes, such as length of hospital stay and patient satisfaction. So I would utilise that more in any future research that I'd be involved with. Thank you very much for listening, and I'm happy to take any questions.
Thank you, Harry.
Take some questions. Jim, then Matt. You've got to take your pole position.
Just to clarify, the choice of allocation to spinal or not spinal is made by the various initiatives who decided on that, and the perioperative analgesia, the people administering that knew which patients had had the spinal or not, have they?
Yeah, so as I said, sorry, so this was just asking about within the study, obviously the perioperative care teams gave perioperative analgesia, and they were aware of whether or not the patients had received a spinal anaesthetic or not. So in answer to that, so yes, they did. As this is a retrospective study, the study was done after the patients had been admitted to hospital. But yes, the perioperative care teams follow the patients on the ward, and ultimately the teams that are responsible for the patient's analgesia are the anaesthetic teams, in PACU and recovery, and then also the surgical teams who follow them up on the ward and prescribe analgesia as and when required according to the patient's needs.
Matt.
Yeah, so you showed beautifully that made the blind bit different, what type of anaesthetic have. What is the future study that you want to do? What's the justification for doing it?
So this is just a question about asking about the future study and where we want to go with that. So ultimately, I'm under no illusions, it's a retrospective study, it has significant limitations. The gold standard to investigate whether spinal anaesthetic is effective in reducing opioid requirements and improving patient satisfaction would be a randomised controlled trial. Ultimately, it would be difficult to blind patients. You've got a cohort who are going to have spinal anaesthetic and a cohort without, and then you would standardise all the perioperative care that they receive in opioids and non-opioids use, and also their recovery and rehabilitation programme. But ultimately, that's where we want to go, to isolate any other confounding factors to see if spinal anaesthetic is effective in these patients.
Question?
Thank you very much for the study. Were there any significant differences between subgroups, so gender, age, or?
No, so I didn't outline the data just because it was really data heavy on a slide, but they were well matched in terms of patient demographics, age. We also do cardiopulmonary exercise testing in all our patients in order to risk stratify them, and they were well matched in that area. The only factor that was different between the two groups is we saw a higher level of preoperative cognitive impairment in patients receiving a spinal anaesthetic, and potentially anaesthetists obviously meet their patients at the pre-op assessment and recognise that patients with cognitive impairment are higher risk of experiencing post-operative pain and complications, and that could potentially inform their choice of anaesthetic care.
Hi everyone, thank you very much for listening to me talk today about something I'm very passionate about, research and prescribing. Okay, so who am I? Why am I so bothered about all this green stuff? So I'm a junior doctor in York and Scarborough. I studied environment before that, and I found myself thinking we've got loads of patients in my GP practice in Scarborough who need social prescribing. We've got this beautiful environment around us. Why aren't we utilising it? So that's when green social prescribing came in, which hopefully I'll teach you a little bit more about if you don't know what it is. So green social prescribing is the practice of supporting people to help their health by engaging with the wonderful nature that surrounds us. It's a type of social prescribing, so things where you utilise things that are already available to help your health rather than medications. And there's loads and loads of things available in Scarborough. People didn't know they were available, and people didn't know to refer their patients to them. So there's things like gardening, conservation, community gardens. There was a seal surfboarding activity. You name it, it's out there. And it's fantastic all the things that are out there. So green social prescribing is so important to us as doctors and clinicians because it can help all these things, and it's virtually free because it's given to us. So mental health is probably where there's been the most research about this. So mental health can be improved from impact on loneliness. So people meet each other, they connect, they engage in nature, and that is led to significant reductions in anxiety, depression, and also just social isolation, which, as we all know, loneliness is one of the worst things that we can do for our health. Physical health, obviously you're getting out and about, and also climate change and all the impacts on our environment that we're causing are really impacting our physical health, whether that be respiratory, cardiovascular. There's lots of research out there. Social cohesion as well. So our communities are getting more disparate. People aren't connecting as much. The old aren't meeting the young. Different cultures aren't coming together. And having something in nature that everyone can freely access is helping everyone come together and share skills, which has been shown to improve health outcomes. And finally, and the thing that I think is most pertinent in the NHS that we're in at the moment, so we're all trying to help patients, but we have no money to do it, is this is a free thing, usually, that can save the NHS money and time. So I was in Scarborough, my GP placement, looking at all these patients and thinking, do you need it? You've got a really nice sea around the corner. But yeah, it really, really needs it. So they're not all just jumping in the sea and sorting themselves out. There's a really, that sounded really weird, didn't it? Well, to me, it's good for you. So anyway, so we've got a really high need in Yorkshire, unfortunately. So our county has an above UK average of suicide, anxiety, depression, chronic MSK conditions, obesity, and Scarborough of North Yorkshire is unfortunately our least fortunate area. So 85% of our most deprived people are in Scarborough. So it's a real hotspot for us to be able to help. And as I've already said about the sea and green spaces, Yorkshire, we're very fortunate. We're all, I think we're the fourth highest who got access of green space within 1 kilometre of us. So we're incredibly privileged in this region. Okay, so I was saying to you before that my project kind of came about because I was talking to people about this amazing thing called green social prescribing, and no one knew what it was, and they looked at me like I was bonkers. So lack of staff knowledge and lack of awareness and lack of confidence in signposting patients to the services that already exist were the 3 things that came up in all my literature review about why we're not using this amazing resource that helps patients and us and the community. So my question was, how can we break down these barriers? So that comes to my aim and my objectives. So I'm going to give you some fun pictures throughout the thing of various things in Yorkshire that we can all go and enjoy. So hopefully you'll go out and try and spot one of these yourselves. So basically what I wanted to do is do a very short talk, educational talk to GP staff, didn't matter who you were, just wanted to talk to you about green social prescribing, why it's important and how we can help patients access it. So the objectives of that were just to get a baseline measurement of knowledge, competence and barriers, and then just see how that changed after I'd nattered away at them for a little while. So basically remove those barriers. Okay, so I had one GP practice and I basically invited anyone in that GP practice to come and listen to me natter on at them. And I also managed to capture a few of them and get them in a clinical governance meeting where I could talk at them without them being able to escape. So the inclusion criteria was literally anyone. So I thought, do you know what? Everyone's patient facing in a GP practice. Anyone can refer and mention green social prescribing, so let's just get them all involved. Exclusion criteria was the patients. I think that's something that would be good to investigate in the future. And also students. I didn't get involved in this particular study. Okay, so my intervention that I did was a very short PowerPoint presentation, a little bit like this, around 10 minutes long. No one had access to any of the slides beforehand because I didn't want them cheating. And then I basically went over benefits, what the services were available in Scarborough. So as I've mentioned, there's some paddleboarding things you can do in Scarborough, lots of bird watching, whale watching, things like that. So I did a nice little presentation for them. And also just how to refer. So you can always send people to the social prescribers or directly just refer them yourselves. As I said, I presented sort of one-to-one and also at this big meeting. Okay, so my questionnaire, it was 10 questions. And basically, before I did the talk, I got everyone to do it. So I found out what they knew at baseline, gave the talk, and then I got them to repeat the exact same questionnaire again before they left the room. So I assessed knowledge subjectively. So that was just saying, how confident do you feel from 1 to 5, 5 being high? And then objectively, so I gave them a bit of a quiz. And I said, can you tell me 3 types of green social prescribing and can you tell me why they're good? And then I also assessed their confidence. And again, that was just on that 5-point self-assessment, so very subjective scale. And that was to do with explaining to a patient what green social prescribing is, and then also their confidence in referring a patient onwards. And then I also just asked them a little bit about barriers to green social prescribing, just to see if that backed up my literature review at the beginning. Okay, so it was a very small GP practice, so I only got 11 participants, but I got quite a good range of people because I kind of let anyone come along. So I got doctors, about 36%, and also lots of pharmacists, but a real range in there, which is good. So understanding and confidence. So this is our 5-point scale, just along this axis here. Understanding, they were saying they're about middly, they're feeling middly about how they feel about green social prescribing and their understanding. And after my intervention, that skyrocketed right up to nearly 100% of them feeling very, very confident, which is great. Sorry, understanding a lot, which is great. Same with confidence and same with that to do with explaining green social prescribing and also referring patients. So we had some really lovely results that people found the intervention quite beneficial for understanding and confidence. I then asked them about the subjective knowledge. So how do you think you know about green social prescribing? Do you think you know a lot? People, again, there's lots of middle answers, which I think is quite a questionnaire outcome. And then after, again, really big improvement in how people felt they understood and not their knowledge about green social prescribing. And then when I did the little quiz for them, things kind of came into a bit more clarity, because it's when you ask them the questions, they have to prove they know it. So, so you can see there that examples they could give me of green social prescribing, the average was less than 0.5. So basically no one could, and a couple of people managed, which fair enough because everyone was in the same boat. And then for benefits, again, less than 1 before my intervention. After my intervention, there was only 3 examples they could give, and they were giving me between 2 and 3, which I think is a pretty good impressive change for them. So the barriers, I asked them to just do a free text box, tell me what barriers there were, and as with the literature, knowledge and awareness will write up in there of the things that are stopping them from getting involved with green social prescribing. And that's just another way of showing that. Something that I thought was really interesting is before my intervention, I think about 6 different barriers to utilising green social prescribing were reported, but afterwards it was only 2. So it seemed to have made people feel a bit more motivated about being able to use it. Okay, so my key barriers, as I've said, were knowledge and awareness. Perceived barriers reduced over the intervention, which was good. Confidence at the start was pretty middling for the referring patients, explaining to patients, and it improved quite a lot. So the referral confidence increased by 43%, and the confidence in explaining green social prescribing increased by 37%. Knowledge, again, poor baseline, subjectively, and also objectively, there was an average of less than 1 example, and that both improved post-intervention as well. And those findings are very similar to the literature that you can see from other interventions about educational interventions to improve knowledge and confidence. So there's a few limitations, as I've already kind of alluded to. So small sample size was my main one, really, and it was a self-selecting cohort for the most part. I captured a few, but a lot of them came to me. So they were going to be people who were going to probably listen more, possibly have a higher knowledge at the start. And I had limited quantitative data. I didn't have the time frame to get the number of prescriptions that people were having to green social prescribing. So my next steps were a larger geographical area. So I really wanted to do this project across Humber and North Yorkshire. Thank you. And I also wanted a longer period of time so I could get more talks and get more people and therefore get my larger sample size. I was also hoping to get some information about prescriptions. So the number of people that are then prescribed green social prescribing after having the talk. So the actual impact on our patients. So in conclusion, there was a really poor baseline knowledge, understanding and confidence about green social prescribing, which highlights all of the literature that we already know. And the main barriers to people kind of improving that knowledge, understanding and confidence was a lack of the knowledge and awareness. So the intervention was effective, which fits in with those barriers. So the intervention improved people's knowledge, confidence, understanding, and reduced barriers. And the results were limited, and it very much highlighted that there's a lot of promise in this intervention, but we need to do a bit more. So since I did this project, we've put some posters into the practice and onto the website and put a lot more talking in that specific GP practice. And then I've actually managed to complete a fellowship to do the project I wanted to do in a large area. So the results of that are in writing at the moment, but it's quite a similar impact, I guess. So it looks like this is quite an effective and short way to utilise this very useful tool a little bit more in our community. And that's me. Thank you for listening.
Yes.
Yeah.
And in particular, did you collect data on social prescription and the uptake of that prescription by individuals prescribed green social prescribing?
Absolutely. So in response to your question, it was just a question about the YESI programme and the fellowship I did and about whether I actually got data about prescriptions. I'm very sad to say that we didn't. We sent an email out to every GP practice in North Yorkshire and Humber saying, please let us know how many prescriptions you've done before the intervention. Even if that's 0, we still want to know, and we didn't get a single response, which was a shame, but we got lots of other really powerful information.
Yeah, the prescribing, I mean, you mentioned the idea that anybody in the practice could refer. Is referral the same as prescribing? What does prescribing actually mean in this context?
Yeah, that's a really good question. Yeah, so basically the question's about whether anyone can refer or everyone can prescribe, what the difference between referral and prescription is. And it's a really good point, because I'm interchanging them a little bit, aren't I? So I tend to mention about referring someone to the social prescriber. So for those who are less confident, there's quite a few GP practices that I've spoken to in my second study who've said, well, I don't have time to do this or something like that. Can I speak to the social prescriber? So refer to the social prescriber, but with the specific aim of green social prescription, you've identified that someone would really benefit from that. And then in terms of prescribing, that can be anyone. So you could say, I think that you would benefit from this specific intervention. Please go see this. So I made a big poster of all the different interventions that people could just freely access. So I would count a prescription as saying, you should go and do this community garden.
Do you think, bearing in mind that it's huge number of people who are off working, quite many people, that this should be prescribed via the job centres? It should be compulsory.
I think you've got a cracking idea. Yeah. So sorry. So to paraphrase, do we think that this should be prescribed by the job centres to people who can't find work? Obviously, there are limitations to green social prescribing. So I wouldn't send someone who's, really struggling physically to go and dig up a garden. But actually, the good thing about green social prescribing is there are so many options. And they do usually feed back into the community. Even if it's something like an art project, then everyone gets to enjoy that art. So I mean, we can't make people do things, but I think offering it would be fantastic, because it helps people build skills, helps them build confidence, and hopefully improves their health at the same time. I think it's something that I think medicine and social care are so interlinked that we can help our healthcare by improving health at the same time as social care. Because I guess, like you say, the isolation and the social cohesion, that's a social care issue, but we can provide something that reduces the number of prescriptions, reduces the number of GP appointments, but also helps society. So I guess it kind of does it all.
You go back when you're still in practice in Scarborough, which seemed an intervention through your media pitch. Is that retained? Does that change the meaning?
So that's
even in that thing?
I haven't, but it's a good shout, and it's something that I'd like to do.
A question?
As a retired professor, I'm congratulating you on your persuasive ability. Do you think it would be possible to do this on a wider scale in North Yorkshire? I think there have been some attempts in Sheffield.
Yeah, so that question was just about whether there was possibilities to do it in North Yorkshire and farther afield. So in the subsequent study that I've done, I've spoken to people all across North Yorkshire and Humber. And then once I've written up that research, my plan would be to then continue that intervention. It's something that I can record and we can send out to people and they can do completely off their own back. It could potentially be something that counts for CPD points and things. So yeah, I think it'd be fantastic to do that.
Great, thank you very much.
And I realized that I'm standing between pizza and a glass of wine. So I'm gonna take, I'm not gonna take too long. I'm gonna talk a lot of research projects. They were amazing, all of them. I'm just gonna talk about a single case tonight. There's no other case reported in the UK, so it's a singular case, and we are working on publishing it. It's about a patient that was diagnosed. He was in Thailand and he was diagnosed with bladder cancer. In Thailand, he came back to the UK. He underwent a biopsy that was confirmed. Unfortunately, he declined radical surgical intervention, and he chose a more conservative approach. In November the same year, the patient had there was a new evidence of a metastatic bone disease. His CT chest was normal. The patient had chemotherapy. He had some radiotherapy. Unfortunately, his pain got worse, and the CT scan a few months later showed that the bone metastasis was enlarged, and then he was started on this amazing drug, which is a check point inhibitor in July 23. His disease progressed in September 24 when he went for further radiotherapy. What does that has to do with ophthalmology? In November, the patient presented to the acute services with loss of vision in both eyes. He had 5 days of loss of vision in both eyes, no neurological symptom associated, and no eye pain. If you remember from medical school, this is a Snellen chart. He was 660, so he could only read the first line when we saw him in our clinic. Anti-nystagmus examination was unremarkable. Now, going back to medical school, these are 2 optic discs. We teach medical students color. This is the optic disc, color, cup, and contour. This looks normal. This is how the picture of our patient. I don't know whether it's clear enough, but this is where his optic disc should be like. So you can't see the color, you can't see the contour, and you can't see any blood vessels, and there's a lot of hemorrhages. So this is classed as severe hemorrhagic optic nerve swelling, or grade 5 on Frisson scale. What do we do in a case of a patient that has bilateral optic disc swelling? It could be, there's a long list of differential diagnoses, but this is a patient that is diagnosed with cancer, underwent a lot of treatments, and we're trying to establish what has caused this problem. It could be high blood pressure. It also could be increased intracranial pressure secondary to a space-occupied lesion. IH not relevant in this case, or thrombosis. He does have cancer, so it might be that. It could be infiltrative, but that's more likely for lymphoma or leukemia. Infectious. He visits Thailand with his partner quite a lot and engages in a lot of risky behaviors. So we have that in mind, and syphilis, HIV, and immunocompromised status could explain that. Inflammatory. Giant cell arteritis, it's less likely with that appearance of the optic nerve, but still he is 67, so we've investigated for that as well, and neurosarcoidosis. Autoimmune diseases, it is something that can present with bilateral loss of vision and poor visual acuity and no other symptoms. And toxic and metabolic or nutritional. It could be antimicrobials. He was not on any. Immunomodulators he was on. And chemotherapy. He wasn't on any active chemotherapy when he presented. So he was admitted in the joint care ophthalmology and the medical team. We did a lot of bloods, inflammatory markers, infectious, with a lumbar puncture to make sure that it's not a paraneoplastic syndrome. That was negative, and we performed brain imaging. So he underwent MRI. This is a scan of our patient. And I think I'm just touching on this because I think it's one of the points that we've learned from this case. Our team of radiology put a comment that the patchy, he's got, there's a patchy white area here and also here. So the patchy white area matter represents PML until proven otherwise. So PML, it's a very severe diagnosis. It's almost like a death sentence. It is a very rare disease. It is severe. It most likely affects immunosuppressed patients. So somebody who's been on long-term treatment of immunotherapy, chemotherapy or steroids, which our patient wasn't. Our patient was on immunotherapy. Immunotherapy enhances your immune response. It doesn't decrease your immune response. So clinically, we thought that the picture does not fit with this diagnosis. So we did not take into consideration, but we have screened for JC virus and our patient was negative. Immune check inhibitors, they are agents that are enhancing our adaptive immune system. They are monoclonal antibodies. They are widely used and mostly in cancer treatment. What do we know about our particular drug? These are the side effects that I found on multiple online sources. The only connection with eyes is uveitis, which is inflammation in the eye. It has been reported with other types of medications, but not this one. There is a report on atezolizumab with Guillain-Barré syndrome. In this case, the patient responded to steroids really well. So going back to our patient, we know that his optic nerves are very swollen. His visual acuity is decreased. All the infectious markers are negative. Inflammatory markers are negative. There was a question about the MRI, but it did not fit with the clinical picture that we had. So that was not taken into consideration. The diagnosis that we made for this patient was inflammatory optic neuropathy linked to his immune check inhibitor treatment. If we're going back to his picture, this is how his optic discs were on examination when he first presented. We administered the patient intravenous methylprednisolone 1 gram a day for 3 days and 60 milligrams thereafter at discharge. And this is how the optic disc looked. The swelling resolved. You could see the disc better, the details better, and his vision improved. So now he was 624 on the right eye, and he was 636 on the left eye. This is just a week after. There was no side effects associated with the steroid treatment that the patient had while he was in hospital. And he continues to be under ophthalmology. Why I thought that this is a very good case together with Dr. Heath, who is our medical ophthalmologist genius in the department. The immune check inhibitors are a cornerstone in the cancer therapy, and they are going to be around for a while. We're very grateful for all the research and the benefits that these patients have, and they have changed the way we do things. But we should not ignore the fact that they have been reported immune adverse effects of these medications. And I think it's very important, both clinicians and patients' education when we're prescribing these new medications. As far as the optic neuropathy, it is rare. I think there's only a handful of cases reported in literature altogether throughout the class of immune check inhibitors. It is bilateral, painless loss of vision, but it does significantly improve once you stop the medication and you start the patient on steroids, provided that you have ruled out an infectious cause. And another thing for the most junior of us, it's very important to look at scans and to order a lot of imaging, but we do treat the patient, not the scan. So it is very important. Every information that you have to put it in a clinical context when you are treating patients. Thank you. There was a study done 10 years ago, and fear of loss of vision comes second after, this is in America, came second after the fear of death. So you should keep your friends close, but the ophthalmologist closer.
Welcome questions.
You have a repeat MRI.
No.
Because it's unusual, isn't it?
It's, yeah.
So did the effective steroid affect?
No, it remains the same, and the patient never had any neurological symptoms to explain that. So we still don't know what's going on with that, but we are monitoring him.
Kim.
This is the first time this has been, have you found previous reports of this particular complication of this particular drug?
Not, oh, sorry. I was asked whether this is the first time this has been reported. So there are studies about different drugs, so different check inhibitors, but not with our one. So not with this particular one.
And is there still a system of reporting side effects, CSM?
Yes, yeah, yes, and yes, yeah.
You think you just expressed the thought that going blind is a pretty big deal. Do you think how should that be incorporated in using the drug in the future? Do you have to tell people that might make you blind?
Definitely. So I was asked whether we have to tell the patients whether the loss of vision is a side effect. I think it's very important to inform patients. We do tell patients when they've got tuberculosis that, this medication can cause problems with your vision. You should report to your general practitioner or to an ophthalmology service whether you've got problems with your vision. And we do have to stop them, unfortunately, and they're not that uncommon. And I think we should do the same with this one. Now that we know loss of vision does not only come from optic neuropathy, it does come from posterior uveitis when the retina is very inflamed. So we've come across that. I think a few years we started when the treatments were introduced in melanoma. They work amazingly, but they do have this. So I think we should educate our patients and tell them about the side effects.
Nice.
Excluded the box of other diagnosis, and you put an association with giving the drug. Is that the same as a causative relationship? Because to then say this is a recognized side effect of the drug, you need to know the causative relationship.
We know that the immune checkpoint inhibitors drive your immune system up, like similar to Guillain-Barré, and it is an exclusion diagnosis. So I completely see where you're coming from, but we could not find any other cause to explain the degree of inflammation of his optic nerves. Yes. 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 No, the drug was stopped when we first put a diagnosis and then the steroids.
Sarah.
What did the oncologist give him instead, or what was his prognosis? Was it effective with life?
Unfortunately, there was no more medications that they had to offer. So he is still having radiotherapy for his bone metastasis, but the options are very limited with such an advanced disease.
Yeah, that's always my worry, we stop that and then they die. So it's a choice, isn't it? Maybe it has to be the patient's choice, which they want.
Great. Well, I think we'll bring it to a
Thank you.
close. Thank you very much.